Every day, people just like you are searching for answers to feel better, live stronger, and finally understand what their bodies are trying to say. Here on PremierU Decoded, we uncover the science and the stories behind true wellness. From hormones and metabolism to the daily habits that shape your future. Because beneath every symptom is a message your cells are sending. And when we listen, we transform. I'm Brandon Williams, and together we're building health, hope, and confidence at the cellular level. Welcome to the place where better begins. All right, everybody. I told you at the end of the last episode that I was really excited and I was going to fanboy today, and I'm sticking to it because I'm very stoked about what we're going to talk about today, and specifically for who our guest is. We've got somebody with us today who has been, I'll say it, in the trenches of medicine, has done it at every level, and has a really unique ability to take care of patients, make a connection with them, and connect the dots for very complex situations. Jordan Kimler is a nurse practitioner at PremierU, and if you've been around, you've met her, you know her. She's awesome. She's a star. She's incredible at navigating very complex situations, taking care of people, and ultimately making that connection, that provider-patient connection that is so very important. She knows the importance and uses it every day of taking the approach to not guess, to not get a one-size-fits-all plan, and has real conversations with her patients backed by science, data, and experience, and can combine that into a unique situation that takes patients to the next level. So buckle up, because this is going to be awesome. I'm excited. I'm about to levitate. I'm how excited I am about this conversation. So here we go. Jordan, welcome to the podcast.
I'm so happy to be here.
Yeah. Me too. So I want to start off, we're going to get to the science, we're going to get to the nitty gritty.
Sure.
But I want to start off with a little bit of a unique question.
Okay.
Something that has to do, like I'm personally interested in, is about that patient-provider relationship, which I think is very important. And I think you do a phenomenal job. I've been around in medicine for now, ultimately seeing patients for 20 years. I've seen lots of people do it, lots of people not do it well, and you do it as well as I've ever seen. So I'm really interested in knowing what that is for you. How do you approach that? How do you make that unique, and how do you create and curate that experience for that patient so that you get what is necessary to get those outcomes?
Yeah, so ultimately I think it's about being able to read people. So my assessment starts as soon as that patient walks in the front door, right? How they check in. I can tell if they're nervous, right? Well, I can tell even by how they filled out their paperwork at this point, like what we need to focus on. Yeah. And I think it's just from the sheer volume of patients that I've treated at this point. And as you said, with my background being ER medicine, hormone optimization, primary care, so being in all of those aspects, I'm able to figure out the way I need to bring, what I need to bring to that appointment, essentially, too.
Yeah.
Yeah.
Well, something that maybe I'm not right about this, but I know that you love the geriatric population.
I do.
Right? What I'm intrigued by is I feel like that your practice has evolved to incorporate a much younger population, which I think is necessary. And I think that that would be a foray into a lot of what I'd like to talk about today.
Sure.
Is to consider that younger population and people that I think are not dealt with well.
Right.
So I'm going to pick a condition.
Okay.
We'll do a sort of conditioned base, and I'm going to let you take the reins.
Okay.
So like, for instance, we know that somebody with PCOS, so polycystic ovarian syndrome, and I'll let you extrapolate for people, but just to give some background, we know in medicine that those patients are not seen, what I'll say, early enough.
Correct.
And I think that they don't get recognized. So now, floor is yours. I want you to talk about how you approach that patient and where you see standard medicine maybe fail, where they succeed, and how that could be taken to the next level.
Sure. So going back with even my friends, right? I think that a lot of us were put on oral birth control. It was any complaint that we had, whether it was acne, whether it was mostly acne or period irregularity, we were just put on birth control. Oh, they're depressed, they're anxious, maybe birth control will help with that. So a lot of us were put on oral contraceptives at a very, very young age. And obviously we've learned a lot about PCOS. It's not just an ovarian problem, right? It's a metabolic health problem. So really those patients should be followed pre-pregnancy, during pregnancy. They're at increased risk of gestational diabetes. They, as you know, too, they're at increased risk of diabetes. So in my brain, I essentially when I'm seeing even an older patient, I'm looking at what happened in their life. Like, were they PCOS and just never diagnosed, right? And there's so much lack of research with PCOS and endometriosis. It takes female patients, about 7 to 10 years to get a diagnosis of endometriosis. And it can be very, very very detrimental to their mental, physical health. It's a chronic inflammatory condition. And essentially it's where there is tissue that's growing outside of the uterus, and it creates real problems for women. And really the only way to diagnose it is surgery, right? So I had a lady come into my practice this week, and I can just tell she has endometriosis. She's been to several specialists, and I can tell by her presentation of symptoms. And something I will say about women is that, and I hear it all the time, it's, well, my pain's not that bad, right? So it's like a badge of honor to say that, well, my pain's not that bad, right? And just based on her symptoms, and she's been to all these specialists, I'm like, has anybody talked to you about endometriosis? Like, I think that's what you might have. And she's like, I've done my research for pelvic inflammatory disease. I think that you might be right. But nobody's ever provided her any sort of guidance. Yeah.
Well, so I want to go back to something that you said. And I make sure that you agree with this, what I'm about to say, because this is your field. But so endometriosis and that idea, I think would you say is moving towards that is a clinical diagnosis, right? Like, you can sort of interview that patient and kind of know? I
think so at this point with as many patients as that I've evaluated and treated. I believe so. And like I said, the really only way to officially diagnose this really is surgery. But by the time they have surgery, they're like, oh, we got in there and there were adhesions everywhere. It was a mess, is what I hear time and time again. There needs to be more research.
Right.
As you know, there's a lack of research in women in general, but especially women 40 and older, and then also with endometriosis, PCOS.
Yeah. So tell me about how you approach that patient. So let's say you do have somebody who's a new patient, and you say, hey, I think this is endometriosis, and sort of they check the boxes. How are you approaching that patient? Tell me about strategies you take for that.
So obviously looking at their hormones, making sure I can balance them as best as possible, whether that's through lab work, whether that's presentation of their symptoms during certain parts of their cycle, making sure they have enough iron, because a lot of times their iron stores drop because their periods are very, very heavy. So making sure I can support them with vitamins, potentially hormones, and then lifestyle as well. So anti-inflammatory diets, things of that nature. Obviously, I don't perform surgery. That's kind of a joke in our practice. We do pretty much everything but perform surgery at this point. So ultimately, it has to go to a surgeon in order for that to be really taken care of. But I try everything I can do from an anti-inflammatory standpoint. Yeah.
So let's talk. So the scientific part of it, talk about sort of the hormone piece. We know that in a patient that has endometriosis, they tend to do better when they're pregnant.
Right.
And when they're breastfeeding.
Yep.
Which would mean to me, as somebody who's not as well versed, that is a hormone response, right? That is something that has shifted. Can you pull that out?
Yeah, I mean, we know too that is it estrogen related? We know that prolactin levels are obviously elevated when you're breastfeeding. Is there something to do with that? But there just really needs to be more research in order for me to definitely say what's causing it.
Sure.
Yeah.
Okay.
So it's a lot of unknown.
Yeah.
And those women don't really know where to go.
Yeah. Oh, we see that all the time. And that thing that you said earlier about having to use a laparoscopy to diagnose.
Yeah.
I mean, that's an invasive procedure.
Absolutely.
That's surgery, right? So let's just say it what it is. For those that don't understand, and that is putting cameras and scopes through cannulas into the body, into the abdomen to look around.
Yep.
Which seems archaic, but that has been what has been done. That's been the standard of care for a long, long time, and hopefully will evolve. And like you say, we need to have more data about how to shift that paradigm for sure.
Yeah, for sure. And I think that there are a lot of people that are in like cancer research that are looking at it, because maybe there's modalities that we use there that could be used for those patients as well, right?
Right. So
at a cellular level.
Imaging techniques and
exactly.
other radio tracers and uptakes. Perfect.
Exactly.
So I want to go back to the PCOS, because you mentioned something about the metabolic piece for PCOS. Dive into that for us.
Yeah, so mostly seeing a lot of insulin regulation issues, right? They're eating, after they eat a meal, they crash a lot of times because that insulin's kind of spiking and then dropping along with the glucose. They don't feel well. Sometimes they have higher testosterone than average. So a lot of them are athletes, right? They do very, very well in competitive sports. But the worst thing you can do to somebody, in my opinion, with PCOS is give them oral birth control, because women age 18 to 25, that's really when like muscle development, if they are going to take their high school career to the collegiate level, right, in some sort of event that they're going to do, you're going to lower their testosterone. So like it's good in a way, right? But there's also negatives to it. And I'm not so anti-birth control. I believe that there's a time and a place for that. I believe in pregnancy prevention. I believe women should have access to that if they would like. I mean, what it's done for women for career advancements has been amazing, right? For them to have control. But there are side effects to oral birth control.
Yeah.
Yeah.
So let's keep going on that line,
Okay.
and the birth control part of it. As we've talked about this before, I've said this to you. As a male, it's interesting where I feel like the lay people around me who are females, they know so much more about birth control than I do because they've been thinking about it. It's been part of their zeitgeist since you were young, right? Whereas me, I'm sort of looking on the outside of that. And it seems like such a complicated world.
Right.
And it is very important to understand the differences between what's in this. Does it contain estrogen, progesterone only? What form is that? And then what delivery system? So if you would, talk about that a little bit and sort of pull those out and say, you know, sort of pros and cons, kind of what you like.
What I'm seeing too in my practice from patients, right? So the easiest way to put it with oral contraceptives, it essentially tells the brain to not talk to the ovaries, right? It kind of cuts off that communication. So if you think about that, our brain likes estrogen. We know that, right? Yeah. So we start to see brain fog, and then it also starts to occur where they start to see low libido because it decreases that testosterone. In some PCOS patients, that can be a great temporary tool, right? Where you're trying to fix everything, but it really, really shouldn't be the fix all when it comes to that. You think about women also on oral birth control. We are still having GYNs put women in their mid-40s on oral birth control as an alternative to hormone replacement therapy. Well, birth control, those are synthetic hormones. So they behave very, very different than bioidentical. I don't really technically love that term, hormones, for HRT. Yeah. So essentially it's a Band-Aid on an issue, on an underlying issue.
Yeah.
Yeah.
I was thinking about this idea of, since you mentioned it, about perimenopause, sort of this change, and then the idea to use birth control or things that are synthetic, and that sort of whole version. But let's talk about that. The perimenopause piece that I feel like is getting better recognized now as something that starts early for people, right? That we get affected earlier by that. So
yeah, I mean, it can start in your early 30s, right? We say women can be in perimenopause. There's so many statistics out there for 15 years. Let's just say that, right? Hormones start to change. They start to shift. Progesterone starts to decline in the early 30s. But I treat a lot of even younger women with low progesterone issues. It's hard to say, is it our environment? Probably, which I'm sure you'll talk about at some point on this podcast. Is it our processed foods, all the things? Yes, I think it has something to do with that. But with perimenopause, yes, I'm so happy we're having these conversations, but it's amazing to me, even though we've came so far in the last few years from that early women's health initiative that came out in the early 2000s that scared every primary care doctor, every OBGYN away from hormones since retracted, but there's still that fear that's lingering with both providers and patients. And I think it's easy for us to say that's getting out there, but really there are patients. I had a lady this morning come into our practice, she's like, wow, this was the most insightful lab review I've ever had. This is exactly what's going on with me. Yeah. So I just didn't know what to call it. Yeah. And as you know, I don't really like labels on really anything. It's just something's off. The hormones are changing, and then this is what we need to do about it. Yeah. Yeah.
I think you're right. It's one of those things that I know I take for granted that everybody else hears this information because I live in this bubble where I've immersed myself, and purposefully, to live in this place where I'm sort of on the cusp and learning about just, probably similar to you and how you probably feel about this. And then the reality is that this is not common knowledge. And people don't just know that. And it's a shame. We talked last time, Shannon asked me that question about the Women's Health Initiative and what it led to, in the years that it set us back.
Decades, and it's still lingering, right? We finally have the black box warning off vaginal estrogen, which has been amazing, but there's still vaginal estrogen circulating with that black box warning on it. As you know, vaginal estrogen is safe for anyone during any hormone shifts, because that's something too. Hormones are dynamic. They change, right? They're chemical messengers in our body that send signals to a reaction, essentially, that's going on. So they're dynamic. So I will even use vaginal estrogen on women on oral birth control, because you can have vaginal dryness, UTIs. I will use it in women postpartum after pregnancy, because hormones are changing. So vaginal estrogen is really like invaluable when it comes to, if I could pick one hormone, that would be it for sure.
Yeah. This next statement, I'm going to make it because I think it's important. I debated about whether to say it or not, but I was reading a paper this morning, and I was reading a response to that paper this morning. And it's something that has bothered me, and it has to do with this phrase, and I'm going to poke some bears here when I say this, and that's okay.
Yeah.
This idea of what's called evidence-based medicine, right? We've all heard this before. It bothers me. That phrase bothers me considerably. I see that phrase of evidence-based medicine as this, what I'll call it as a veil of convenience for people who are intellectually lazy.
Correct.
I'll just say it.
It's a pitfall. Yeah.
Right. Because it holds the entire medical profession back. Really, the reality of evidence-based medicine is that's the thing we have the most information gathered about. But it doesn't mean that it's correct. And it completely disregards this mechanistic data, the thing that leads beyond like, oh, my society says that this is okay or this is the way that we treat patients. Mechanistic data and other data comes 10, 15, 20 years before
it's too late.
The population
a lot
changes,
of times, right? Similar with GLP-1s. As you know, at this point, I've treated over 5,000 patients with GLP-1s. I have a wealth of knowledge when it comes to GLP-1s. I've been talking about for years that we don't always see muscle loss with GLP-1s, right? They are invaluable tools for patients if they're prescribed appropriately, ding, ding, ding,
Bing, bing.
and you're monitored when it comes to looking at lean body mass, right? So you're monitored, making sure you're looking at muscle, maybe potentially getting DEXA scans on patients. So, but they're invaluable tools. So I think I spend most of my consults educating on patients on things we're not hearing evidence-based practice talk about, right? But I see it in my practice every day.
Right. Well, and like to your point, I just also read this morning a paper that's new, just came out, that it's with respect to this idea of muscle loss with GLP-1 use. And it's that the data that was gathered, so this is the point and part of my criticism of this evidence-based is how was that data gathered? And the consideration of GLP-1s, and they've made this concern that like, so for perspective, lifestyle intervention leads to a 25% loss of lean mass, so like diet and exercise, whereas GLPs have been quoted to cause you to lose up to 40%. But the reality is this study was able to elucidate via biopsies that what they were losing was substrate within the muscle, but not muscle mass or strength, actually. So it changes that framework of how concerned, like we've talked about before in practice, and when we lecture and talk to patients, we say, a lot of times the GLPs will cause a shift towards more metabolically efficient muscles. Right.
Maybe that muscle was inefficient to begin with.
Yes. So changing even muscle fiber types. That's obviously early research and mostly animal models, but it is an intriguing concept that has to be considered. And I think throwing it back to you now, and this connection that you have with that patient is thinking about them and their functional life.
For sure.
Thinking about the fact, well, there's this data and evidence does say that, but what does this particular patient look like? And that's precision. We use that word precision medicine, and maybe it sounds pompous, but I like it because I feel like it's a little bit more poignant. No,
I absolutely agree with you. And, I've struggled with that in this journey that we've grown this to what it is today. And it's like, what do you do for work? I'm like, take care of patients really well. I don't know. I kind of use your line like anything but surgery.
Yeah.
But you're right. Like I give patients the tools that they need to be successful. I meet them where they're at, right? And it's not cookie cutter at all.
No.
It is precision medicine that I'm practicing. And the only reason I brought up GLP-1s is because I do utilize them a ton in my practice for women with PCOS, women really going through any sort of hormonal weight gain changes. They're invaluable tools for them.
Yeah. So I think for maybe the patient who has been struggling with PCOS and hasn't heard this before, right?
Yeah.
To make sure that we include them and not take for granted that they know this.
Right.
So let's take that PCOS patient and we'll pick some, we'll use GLP-1s because we were just talking about them. But that tool in context of everything else that you're doing, what do you see change for those patients? And then I'll ask a second question to follow up.
So many changes. I got a Fatelamed this morning. She's been on GLP-1 for about a month.
Okay.
She is down about 9 pounds of body fat. Now we have a long way to go, obviously, so she has more to lose. She did maintain her muscle mass this month, but what she tells me is she has an overall sense of well-being, global sense of well-being. And I can report that as well. As you know, with my weight loss journey, losing over 50 pounds, we're coming up, I think, on 4 years, which is amazing. Wow. Hard to believe it's been that long, but that's what I noticed too. I just felt better, right? I didn't have as much inflammation. My rings started fitting better, things like that. I wasn't losing a ton of weight in the beginning. I also felt like I had control because also with PCOS, insulin changes, you start to see cravings, especially sugar cravings, right? The term food noise. It's hard to say what that means for each individual patient, but really it's just thinking about your next meal or maybe not eating, then binge eating, those type of behaviors. I find that patients feel more in control of everything. They're able to make decisions about even other things in their life because they don't have to obsess over food.
Yeah. That's something too, that sense of well-being, and it's hard to how do you put a finger on what that means, because it means different things,
and you see it in them, right? I mean, you and I know as providers, well, not all providers know, but when we see the patient, I'm like, gosh, she just looks good, right? She's glowing. You can just tell her face. It's not as puffy anymore. She just feels better overall.
Yeah, and that's something you notice. You spoke about this, but as soon as they get out of the chair in the waiting room, you're sort of assessing them. Yeah, all the way from the waiting room, their interaction with the front desk, all the way down the hall, getting on the in-body scan if we're doing that visit. And it's just amazing, the patients that really want all the information. As you know, you're like, how much of this do you want to do and how much do you not? But I had 2 patients this morning that were like, I want to do it all. Let's just go. And I said, I'd love to go all in because then hopefully later we can start peeling back. But there are those patients that you do have to just make those small changes with, and that's okay too, right? And GLP-1 is not for everybody. I'm not saying that, but it can just be a great tool if needed. Right. Yeah, people, we hear, so we interact with that world that will say, oh, that's cheating, right? Right. I love that. Yeah, we love that, right? Yeah. So, but the reality is it's a tool, right? And you have to use it, and you still have to do you teach patients that they have to do the other things, or they should do the other things, right, to augment this. Yeah, and I mean, I think that we could probably segue into lifestyle is paramount, right? You talk about sleep on here. I talk about sleep every day. I talk about nutrition, exercise, managing stress. I talk about all those things because they are paramount, even when it comes to hormone replacement therapy, which we're not there yet, but when it comes to hormone replacement therapy, they're just a tool in your toolbox, right? Right. I have a lot of women come in and they're like, I just want hormone replacement therapy. I've heard it's going to be life-changing for me. And yes, while it is going to be life-changing for them, they're going to have less osteoporosis, less fractures. They are going to be have more cardiac protection, better insulin sensitivity. But in general, you still have to do the lifestyle things, right? And that's where I struggle too sometimes as a provider, sitting down with a patient that's so metabolically unwell. And I know they need estrogen. I know they need progesterone. I know they need testosterone. But I still, even myself, with all of the knowledge that I have and the data, it's like,
am I putting these hormones into an unwell body?
Yeah.
Right?
Sure.
But I still do it, even though that goes through my mind, because what I've found, and my patients have proven this to me, that even if they're not quite ready to make some of the big lifestyle changes, without those hormones, they aren't motivated to do so.
Yeah, and there's that phrase of patient buy-in.
Yeah.
Right. So that, there's a certain point where, we'll talk about, and, this putting fuel into a dysfunctional system. And I think I talked a little bit about that last time. But there is that part of when you just feel like crap, you're not going to do any other stuff.
Let's just fix it. Right. Let's see if this. Now, obviously, if I have a patient come back after multiple visits, after a year, and they haven't started anything lifestyle-wise, then we do talk about benefits versus risk. But that doesn't happen.
Yeah.
It's maybe happened once.
Yeah. So let's talk about this is, again, to consider those that don't live in this world. This idea of concern and fear related to hormone replacement therapy, hormone replenishment, hormone augmentation, whatever you want to call it. Right. There's all these vernaculum that exists around that. So how do you, and I know you do a great job of this, how do you work with that patient to educate them? What do you see normally shifts that for them?
So honestly, for me, I have found it's going line by line on their lab work, right? And when I'm going line by line, talking about the differences between normal and optimal and all of that, I start with like a comprehensive metabolic panel, a lipid panel. So they understand like, hey, she knows what she's talking about here, right? Thyroid, I kind of jump into that. Yeah. Then we lead into sex hormones, which I've already said are very, very dynamic, especially in the perimenopause transition. So here's what's different about me. I'm honest with that patient. I'm like, yes, I love to get baseline hormones just to see where you're at, but this is literally a snapshot in time, right? I could draw your estrogen tomorrow. It could be sky high. I'm looking for some estrogen producing tumor somewhere or something like that. So I say to them in that moment, and I look at them and I say, your symptoms mean more to me than this estrogen progesterone. I'm using it, I'm looking at it, but your symptoms mean more. Your age, when did your mom go through menopause, your GYN history. I take all of that into account, whether I decide to move forward and discuss those things. So I think it's just being real and raw and honest with patients.
So wait a second. You don't just spend 5 minutes with people? Is it?
An hour for new consults for lab reviews. Yeah.
Right. Which, we talk about, and I'm the worst about criticizing, but I do give a grain of salt to the fact that primary cares don't have time. OBGYNs don't have time because of the standard medical system, right? Yeah. They have driven this volume and speed-based medicine approach, which is why we're different. I think we attract people, both providers and patients, but also staff too, who are interested in this different format, which isn't easy, right? I mean, what you've just described is really hard, right? I practice that way. I know that you do. It is not easy. It's very difficult to deal with the psychological aspects of things, to deal with all of the nuances of all of the available treatments. And I tell people a lot of times, I'll use this phrase, look, I've got 1,000 tools. I need to figure out which ones of those to use, which ones to not use, how much of them to use. And, and I have to have this relationship with you that there can be good feedback so I can make that decision, because it's not perfect. I'm not perfect. I'm a human. You're less human and more perfect than me in this. But ultimately that is tough. And that is part of why I started the conversation where I did, is that your ability to navigate just that, I think, is super unique. And so I want to take that a little bit further now to talk about, we'll talk about the perimenopause side a little bit, because I want you said something earlier that was, patients want these results and they want them quickly.
Yes.
But we know that their brain health, their bone health, muscle mass, these other things that happen are super important, but they happen over time. Those are seen chronically, or you're trying to salvage them from this issue that's going to happen to them in 20 years. And I'll say to people, you probably say something similar, I'm worried about 10, 15, 20 years from now, you.
Right.
So talk to me about how you educate people about those factors.
Sure. So Occasionally, ultimately it depends on what we're going to move forward with. I think I will say that I talk to patients about what's going to be easily integrated into their life, right? And I do, as you know, I do a really great job, and I will say that because I feel like I do, of trying to help them prioritize. Yeah. Because a lot of times they're leaving my consults and there are a lot of things I want to do for this patient. Same with you as well. And I understand financial constraints can be an issue, right? Because that can be a little bit of a problem. We are a unique balance where we will utilize insurance for some hormones and things where some practices will not, straight cash. It really depends on what the patient and I decide together on what the education is going to be. I really try to set the stage that you talked about my passion for geriatrics, which I still have. There's a reason I'm an adult geriatric nurse practitioner. I'm not a family nurse practitioner. I started my career, it will be 20 years next May in healthcare, right? Or this May, sorry.
Like 2 or 3 years old, right?
Yeah. But it's crazy to say 20 years I have been in healthcare. And I started when I was 16, so I'm giving my age away there, 16 at a nursing home. So seeing those women struggle with UTIs, and at that point I didn't quite understand, but now like outside view looking in, struggle with UTIs, hip fractures, spinal fractures, dementia, Alzheimer's. And it's amazing now that I'm trying to prevent women from going into that nursing home, right? To prevent them, because women, we live longer than men, right? We live longer than men. What is it, about 6 years? You probably know the data on that exactly.
Even beyond us just being stupid. Yeah, you guys just live longer physiologically, right?
Yeah, we live longer, but we don't live well longer, right? Yeah. We're 2 times more likely to end up with a mental health issue. We are 2 times more likely to end up frail and in a nursing home. So, my passion is geriatrics, but my passion is I want to see a healthy, active geriatric population. Yeah. And I'm hopeful that you've said like over time, I've shifted to treating earlier and earlier or younger and younger patients. And it's because of that. Like if I can meet with someone when they're 18, 16 years old, get a good set of labs and set that foundation, they may never end up in a nursing home.
Right. Yeah. That goes to, this is in the vernaculum, even in the general population, of this idea of longevity or lifespan. It seems to be everywhere, right? So we talk about health span, this other phrase of muscle span. But that is unique. And that is something that's kind of why I brought that question up earlier about your shift earlier. I have a 20, almost 21-year-old daughter who is, I trust with Jordan. So I'll say, that's something that is important. And I know that that's part of this for you, is that you're seeing these patients and saying, I have to intervene earlier because otherwise you're going to dig this hole for yourself. And if we can do these things and make these corrective actions, and plus, so you don't feel like crap for 20 years,
who wants to?
And then to feel like even worse crap later, once your body is, the juice is gone, right? You've lost these very important signaling agents of your body that need to be changed. So, expand on that a little bit of, these patients and what you will see and how it shifts for them, their mentality of when you're seeing those young patients, because their life, they're at a different phase in their life. So it means something different. Maybe it's college becomes more productive. They're better at stuff. I don't know, whatever, making something up, but yeah.
It mostly is cognitive. A lot of times when I'm seeing the younger patients, and where that's shifted, I'll kind of talk a little bit more about that. It's since my population is getting a little bit younger and younger, it's because I was getting the woman that's 52 years old. Average age of menopause is 51, 52. She's postmenopausal, which I don't, once again, love labels, but 1 year post-period. And her cholesterol is rising, right? Well, she's already been to her primary care. They put her on a cholesterol-lowering medication. She's also on anxiety medication. I'm like, oh, when did that start? Well, I was around 36, 38. Okay. And my brain progesterone's declining. Okay. Yeah, so I'm constantly doing this with every single consult. I'm like, oh my gosh, well, if I would have just saw her sooner, like maybe she would never had to go on those things. And I believe that there's a time and a place for SSRIs. We've talked about that, but it's like nobody ever looks at root cause when it comes from a hormone aspect to mental health.
Yeah.
Other than us.
Right.
So.
Right. It is the standard way of, you have these depressive symptoms and you're not menopausal yet. So it's not considered, we won't
no
consider
big deal.
hormones, no big deal. And there are obvious benefits of SSRIs and some of the other drugs meant to treat anxiety, depression, and, that's a real problem. But yes, shifting it towards, okay, so that's fine. And maybe that needs to be there, or maybe it needs to be there later, or maybe at a lower dose, but let's support the
everything
physiology.
else that's going on here, right?
Yeah.
Even omega-3s, right? We have omega-3 to 6 ratios that are not appropriate. We don't eat fish. We're in the Midwest. We don't eat fish in the Midwest. Even if we do, we don't have great quality fish that we have access to. So omega-3s, that's a staple in my practice for anyone, honestly. They're leaving with vitamin D with K2 and some omega-3s.
Yes.
And some creatine.
And some creatine. Got to have that creatine.
Yeah, got to have that creatine.
Particularly for our females. Got to have that
Particularly.
creatine. Yeah.
And I know you've talked about cholesterol. So with women too, I find this interesting. I got extremely frustrated. This is on topic, off topic, but I think it's important to talk about. So I had a lady come into my office this week and she's like, my doctor is angry with you. I'm like, okay, let's go. Like, I'm ready. I'm used to this.
What's new? Yeah,
what's new?
That's Tuesday. Right?
Well, that nurse practitioner, she just keeps putting everyone on testosterone. Okay, well, first off, I don't put everyone on testosterone, right? You know that. Yeah. If it's needed, yes, I absolutely do. If it's appropriate, yes, absolutely to optimize that for them. She just puts everyone on testosterone, and she just doesn't really think, that testosterone is not FDA approved for women. And I'm like, oh, here we go. Okay, but it is in other countries is what I'm thinking in my head. And I'm letting her talk. And she said, well, I stood up for myself. And I said, I'm the best. This is the best I've felt in years. And I came to you with multiple complaints. And you just said, high five, have a good day, right? Essentially. And you didn't know what to do with me. So I went to Jordan and she's fixed me and I feel better. And I'm going to stay there. If we need to stop this relationship, right? If you don't think that we're a good fit anymore, I think we might not be, then I'm going to find a new primary care provider. Yeah. So I love that, right? It was amazing. Yeah. But I sat there for a second and I said, that's interesting. So testosterone's not FDA approved for women. However, we've been treated like little men, right? So it's FDA approved for men. So why is that any different for the women? And I'll explain where I'm going with this, right? A lot of the cardiac studies are based on men, right? Who tend to have like large clots, like in the LAD, left anterior descending artery. They tend to have the widowmaker, right? Creates widows. So statins, which you've talked about, right? Predominantly those studies were based on men, right? So I thought to myself, well, you're on a statin. He had no problem putting you on a statin, which was primarily based on men. So why is it not okay for me to give you a 20th of the dose that I would give a male patient at this point? So in my head, I was kind of doing that circus. I haven't talked to you about that.
Yeah, that is interesting. And that kind of goes back to the point, I mean, not to go off on an FDA rant for a second, but I think that, and I include myself in this statement, people give the FDA a bad rap, but the FDA does have a role.
Sure.
It doesn't have to be involved in everything. Medicine and providers are causing that problem. It's that provider saying, well, it's not FDA approved. Well, get with it, bud, because there's lots of stuff that's not FDA approved for X, Y, or Z condition.
Right.
You've heard me say this 100 times because we treat a lot of neuropathic patients, neuropathy patients. Gabapentin is not FDA approved for neuropathy. However, it is the most commonly prescribed drug for neuropathy in this country. So almost every internal medicine doctor does non-FDA approved things every day.
Right, Topamax.
Yeah, there's all kinds of stuff. This list is huge. The reality is that they're having these sort of talking points because they don't have
what they
comfort.
choose. You're right. They don't have the confidence. They don't have the knowledge. And and some of them do want the knowledge. Like we work with some really, really great primary cares and GYNs in our area.
Yeah. Oh, yeah.
But most of them are set in their ways, right? These are the 4 medications that I prescribe. This is what I do for this condition. And I understand that world because I worked internal medicine for a while. It is a very, very reactive healthcare system. It is mainly insurance driven. Right? 15 minutes with the patient. There's no way you can appropriately treat someone really at any age in a 15-minute visit, especially a patient in their 50s or 60s. There's no way.
No.
You're missing something.
Yeah, and you've got that. You could talk about one thing,
One thing.
You get to talk about that one
Shannon
thing.
talked about that on the podcast. Yeah.
Yeah. But that one thing may have 6 other peri-related things or intricately related things, but there's just not time for that.
Right.
So to follow a patient, and you talked about this a moment ago, so let's say that you utilize hormones for that patient, those molecular signaling agents, and that there are changes made, the follow-up then takes a lot of time.
Absolutely.
To go through the goods and the bads. How can we tweak this? What does your dose need to be?
And so when I establish a new patient on hormones, so it's our first visit, we have a plan of care, I say to them, listen, I'm starting you at these levels. This is where these type of hormone level, milligram strength, essentially. I'm starting you on this dose. This is not where you're going to stay, most likely, right?
Yeah.
Things may change, but I want to let you know I'm here because you're 45. Things are going to get a little crazy here soon, especially around 48, sometimes a little bit sooner than that. Estrogen spikes are super, super high. Said, you have to call me because I don't need labs in order to help make a decision. Your symptoms can help guide me. So make sure you reach out. Typically, I'm drawing labs on patients every 3 to 4 months, quarterly at minimum, especially in the beginning of care. But I will occasionally spot check testosterone if I start a patient in 5 to 6 weeks just to make sure we're not having any side effects, everything is good. Progesterone dosing, I will adjust that after a month or 3 weeks on a patient. So actually pretty quickly.
Yeah.
Yeah.
And testosterone is something that I use personally, TMI, but I use it personally, and I also prescribe it regularly, interact with it a lot. I'm very intrigued by timing of change that you see between the steroid hormones we'll talk about for females specifically. So if you understand that, what I mean by that.
I do. It's tough, right? I think as far as like when they can notice positive change, and that's with every hormone. Testosterone, I've even had patients on it for 5 months that all of a sudden are like, I don't know, just out of nowhere, I'm feeling better. And it's hard to say like what's clicked. Like, and I think for you, maybe like what's going on at a cellular level, what did I change that kind of made that shift? Because their levels are better and they've been better since month 1 or 2, but really they didn't notice it until month 5. So that's interesting there. But also it's like, do they have more receptors or less receptors than other patients? Yep. My brain's always trying to think about ways that why did they respond so quickly and they did not. I've had women either if it's subcutaneous inject their testosterone and in a few days be like, hey, this is life changing for me. But I will say that's an anomaly, right?
Yeah. Do you tend to see that more with the injectable?
It's hard to say. I mean, we work with a really, really good compounding pharmacy that does a great job with our compounding creams. Right. They're highly, highly effective. That way
about the transdermal.
I didn't, right? Because of androgel.
Right.
Androgel's junk. I mean, how many men have we treated where their levels are lower after they start? It's insane. So in my opinion, I don't love the androgel, the foams, but somehow in this base that our pharmacy is using, it's just working.
Yeah.
It's absorbing.
Yeah.
Yeah.
Interesting. That's an interesting part of it. Like you said, what else has changed for that patient, and for the audience to talk about this idea that, and I think a lot of providers don't take this into regard, the ideas of normal and what is an appropriate dose, right? Because that's influenced by genetics. There are genetic phenotypes that have to do with androgen receptor density.
There you go.
And this is something that is measurable, but is not measured in a normal context. Like even practices like ours, we don't do that regularly. No. Just because the application of that in real life is like, okay, maybe there's utility, but let's come at it from a different format. But at least we consider it.
Sure.
That maybe that's why you're different, or maybe your androgen receptor density is lower genetically. Your phenotype sets you up for that, but maybe it does shift because I've been listening to Jordan. I've been doing these other things that she asked me to do. And now that the symphony sounds the way that it's supposed to, the body starts to react differently to those signaling agents. Kind of referencing what you said about putting fuel into a dysfunctional fire, into a dysfunctional system.
Dumpster fire.
Yeah, but if you've corrected that with these other, because you're doing multiple things. It includes the medications, the lifestyles, the sleep. I won't go off on a tangent, right? Supplements where necessary, these other things to do, but also just, mindfulness, getting in touch with your body. I think for a lot of people, and I'll say this, and maybe you recognize, but I recognize this from the patients that you see because I see them for maybe some other reason. that it may be the first time in their life that they think about their body in a way that is more intuitive. Because you've asked them the right questions, you're probably the first person to have done that in their life, despite the fact that they, particularly females, you start seeing a doctor regularly, annually, at a young age. Whereas, guys don't do that. Like, we don't go to the doctor ever, even when we're 90. We
guys
don't go to
are
the doctor.
easy.
Right. We're dumb. I said that earlier. But it's an interesting shift that happens for people to say, whoa, like I need to be in tune with myself. And I think that does start for a lot of people after you've asked the right questions and spent time for them and made them realize that, there's a different way to do this, a way that I've never had in the past 30 years that I've been seeing doctors regularly. Right. I would bet that that's true. Do you agree with that?
I agree, absolutely, yeah.
And I don't know if that's true for like somebody like you, right? Because you think about these things. If that's true from your experience of seeing providers too, that you leave the experience being like, why did I even do this?
Oh, I do it all the time, right? I think I've told you about going to dermatology. We've had a couple employees in our practice that have had some, cancer cells removed and things. And I'm like, I probably should do that. I'm a sun lover, so I probably should go and do that. So I go in and I just wanted a skin check. That was it. This was last year. And the provider was like, well, what brings you to see me? And I said, well, I just kind of want to get my skin looked at. Was there an area of concern? And I said, well, no, not really. I do love the sun. I used to do tanning beds in high school. And she's like, oh, so you don't have an area you need me to look at? And it took everything I had not to walk out of that room.
Yeah.
So
Sure.
I've experienced it firsthand as well. And it's like, I thought this is what we're supposed to do. I thought I'm supposed to, I can't see my back and my shoulder. My husband isn't a medical. He has no clue what he's looking at. I'm sure he's not looking at my shoulder. Let's be honest with that. So.
He's not thinking about that like a dermatologic case while he's doing it. Yeah. Exactly. It's, the area is my person. I don't know, like the largest surface area organ of my body. And I'm medical,
right? So I feel like I provided the info that I should. I went into that visit. I was very straightforward. So I can't even imagine, a lot of these women don't even know that they've been dismissed. They don't even have a clue. They just think that that's what it is.
Yeah, think of how many people we've caused to be pissed at their doctors after they see us.
I know. They're like, oh, will you start taking over this? I'm like, I don't know yet.
Yes. Yeah. Oh, you get that all the time. Yes, I do know. Like, can you just manage this?
Will you be my primary care? I'm like, same day sick visits. I'm kind of done with that. But
I'll do all the other stuff. I got you.
Metabolic health, hormone health. I'm your girl.
Yes, exactly. So one other topic, and we could spend as much time about this as you want to, but I'm very intrigued to talk to you about the thyroid.
Okay, awesome.
We're talking about hormones anyway.
Yeah.
Right, to talk about this organ, and I'll start it off with something that I'll sort of lob it up for you. This idea of subclinical hypothyroidism, the incidence, the prevalence, what you see in practice, and and then we'll kind of take it from there.
So I diagnose Hashimoto's. Approximately 2 times a week in my practice. That's just myself. That doesn't include Heather, our other locations either. And we're seeing record high numbers of it. Right, it's the number 1 autoimmune disease in the U.S. right now, and it's hard to say why. Well, there's a lot of speculation of why we're seeing that. Autoimmune in general, we're just seeing a lot of that.
Later, I'll put my tinfoil hat on. We can talk about it, but
Brandon will do a whole podcast on autoimmune. So I am seeing a lot of that. I'm also seeing a lot of women, and John Gorman, who we kind of work with sometimes with our clients, our patients, they're low carb. So their thyroid's just not functioning appropriately because they've been low carb for a really long time, or they don't eat carbs because they think they're bad. So we'll see issues that way. But as you know, the thyroid affects everything. One thing I will say is that what frustrates me more than anything, why do we treat a woman during pregnancy different than we do postpartum after pregnancy, right?
Same woman, right?
Same woman.
Yeah,
same woman.
Receptors.
Actually going through a lot, maybe a lot more postpartum, mentally, physically, right? But it's amazing how many women, they will check their thyroid during pregnancy, and there's a super tight window. And I love that Quest is starting to do that, right? It gives the reference ranges if the female patient gets labs and they're in I don't know the age actually, when it's probably 50 honestly when they stop reporting that, but it will actually say like during first trimester, during second trimester, your TSH should be below 2.5 really is what it's saying. So then you get labs, you're older than 50 and it says your TSH or if you're postpartum, anything above 4 or anything below 4 is fine, right? So anything below 4 is fine. And everybody's just looking at TSH. Well, thyroid stimulating hormone is not the end all be all, right? We like to look at free T3, free T4 in our practice. We like to look at the antibodies like I had already discussed. So there's a lot of women too that were treated during their pregnancy for their thyroid. They had labs. They might have had labs after. Probably not. Most of them. Some of them do, though. And it's better. Oh, you don't need thyroid medication anymore. And then nobody ever checks it again. It's amazing how even for primary care, I have patients that will get labs every single year with their primary. It hasn't been checked in 10 years, right? But by the time they come to us, it's crazy off the charts. So, we just look at thyroid in a totally, totally different way. And I am honest with patients because it's like, do you need thyroid replacement medication, or can we try some lifestyle things like diet related? Can we try to add some selenium, Brazil nuts? Do we look at iodine levels, things like that? Sometimes I will go down that rabbit hole with them. I will say this, if a woman has family history of thyroid issues, mom, grandma, themselves, and their TSH comes back over 2.5, that T3 is below 3, you're going back on thyroid medication, right? I had a patient also this week. She's had 2 forms of thyroid cancer. So that in thyroid cancer patients, you want that TSH below, super, super low, right? Like undetectable, really. Yeah. Hers came back at 6.
Oh.
So I had her call her endocrinologist. They're like, well, we're not that worried about it. I said, well, I am that worried about it. So I ended up calling in more medication. I said, you need to find a new endocrinologist. So, yeah.
You probably see that pretty frequently too, where I know that we've had these discussions before, shared patients and seen this. They're endocrinologists, and not to classify that entire field because there's goods and bads, just like in every other field. It seems to be all over the map. Where some of them tend to be a little bit more aggressive, like I'll call us aggressive, and I think that is a good way. I take that as a badge of honor, as I'm sure you do as well. And then others that will just let that ride and allow this patient who has checked every box for that hypothyroid, like, come on, we got to treat this.
Let me treat this,
right,
please.
Let me treat this, change this, because like you said, it goes everywhere. That hormone interacts with every system in our body in a good or a bad way, right? So let's talk about that for a second.
Yeah, sure.
So this idea, you get this patient who, I'm going to pick something that's just slightly like, we'll say that their TSH is 3.8.
Okay.
Right? And they have these symptoms. That's the kind of patient who you're thinking to yourself, what does that patient tend to look like? And then more specifically, what do you notice first? Like, what do they tend to tell you after you've treated it? You're that first person that said, like, we got to do something here.
I love this. Yeah. I love this. So weight gain, fatigue, hair loss. Those are the biggest ones. Dry skin, constipation, which is super tough because a lot of those symptoms are similar during the menopause transition. So I say this probably 6 times a week. I'm like, I don't know if it's menopause or I don't know if it's your thyroid. We just need to fix both, really, and see what happens here, right? Depending on labs and symptoms. Or those patients are like, I listened to this podcast. I read this article. Like, I can't believe you actually draw these levels. This is great. I've always thought I had a thyroid issue. They're so like reassured, and they're so happy that I've found that I can treat their thyroid because their thyroid has been normal for years, like you said. The first thing they notice too, well, cognition. I should obviously mention that as well. I think the first thing they notice is improved cognition. Kind of similar to GLP-1s too, just overall sense of well-being, right? Kind of reporting that. There's like, something's changed. I just feel better. That's all I can say. Maybe weight's coming down, not rapidly. People think, oh, I'm going to treat my thyroid, this weight's just going to fly off. No. That's not what we see in our practice, actually, most of the time. They just feel better. Yeah.
You just gain something back that you didn't even realize you lost.
Yeah. Probably or maybe you thought you'd lost it, but you'd been to so many doctors, or maybe your same doctor you've had for 20 years, and they're like, and you trust them, right? Yep. They've been with you through your babies, through postpartum depression. They've been with you through all these life events, losing your parents. You trust them. Mm-hmm. But in a way, like, you've still went to them with these same complaints, and this thyroid's never been great.
Yeah.
At least in midlife for you.
And you may just become resigned to, well, this is
how it is.
Now. This is me. You know? Yeah. And then you see something on the other side that changes you. And then honestly, you'll start, like I said, maybe you're pissed. Because you're like, wait, I could have been this whole time not feeling like this, which is, it's a good and a bad thing. It's sort of like opening that box and giving somebody a view into, this is what it feels like to not feel like crap every day, which is, it's a obviously wonderful thing, but it's also this, man, I could have been doing this before. And that's tough.
It is tough. It definitely is. And there's obviously a lot of tears shed in my office on a daily basis for multiple reasons, but that's one of them.
How big is your box of tissues? I forget.
I think Tiffany's ordering me one every other month, something like that.
Yeah, we're just going to leave that over there for you because that happens.
Yeah, it happens. It happens. And it's a lot for them to kind of talk about these things. I will say, too, my consults have evolved over time. I'm not only educating them on what's not optimal in their labs, but I also educate them on what's optimal for any labs, too, right? So even if they are optimal, I'm saying, hey, my goal would be to keep this number above this, right? Yep. And I say, and they're like, well, it doesn't really apply to me. I've had a few patients say, I say, but yes, but you have daughters, you have, cousins, you have family, you have friends, and I'm hopeful that maybe me even sharing this, that you'll be able to take that to them if they're ever coming up with issues. Yeah. Sure.
Save them from that same fate potentially.
Exactly.
Particularly for the daughters. We want our kids to live a better life than we had, and this is a big way to change it too, which I know you're passionate about. Yeah.
2 daughters, 9 and 6. So yeah.
Raising amazing little humans that are going to change the world one of these days. I'm quite certain of it. Now I want to shift to something. We've talked about WHI. We've been sort of talking about this idea of menopause, right? And I think both of us don't like the semantics of what is menopause because it's a day, right? It's weird. Like, what's the vernaculum? How do we use this word to describe you're menopausal, you're postmenopausal? What does that even mean? It doesn't matter. Ultimately, it means that your body's not having these, doesn't have these hormones, right?
They're out the door.
Yeah, it's out the door. And that's seemingly permanent at this point, is sort of that shift. So let's take that patient who has not been properly educated, has been in the standard medical system. They come in your door, you see them. How are you approaching them?
Obviously, it depends on medical history, right? Yeah. Looking through that, previous GYN issues, how am I approaching that? I'm just flooding them with information that I can, pertinent information to what their symptoms are. I think I probably focus on their symptoms, right? That they're coming in to see me. Like, well, I have this joint pain. Yeah, that's because of low estrogen, and I kind of go through all of that with them related to that. Les musculus syndrome of menopause, vaginal dryness, going through that. That's because of the estrogen. The cholesterol increasing, that LDL increasing is probably due to the estrogen, going into that with them. It varies. As you know, I'm very, very good about reading patients. How much information are they going to be able to absorb, right? And what information are they looking for, right? Ultimately, I always conclude my visits with, do you feel like everything's been answered? Do you have any additional questions, right? What are your goals for the next 6 months? What are your goals for the next year or 10 years? As you know, in my practice, it's everything that's anti-inflammatory, cardioprotective is a go. And I say that to them because heart disease is the #1 cause of death in women. It's like very, very passionate about that. So talking to them about that, this is the reason we are doing these things. The way you kind of worded that, patients are usually coming to me with complaints, right? They're not just saying, hey, I just want to get things checked out. Occasionally in perimenopause, I will see that. I had that earlier this week. But postmenopause, they're miserable, right? And I know that because it takes a lot for women sometimes to go to the doctor. It really, really does. It takes a lot for men too, and I understand that as well. But I think these women maybe have went to their GYNs, their primary cares. They've been dismissed. So they are coming, and I know that they wouldn't be there if there wasn't something bothering them. I thought about this the other day when I've been dealing with this SI joint issue after we got back from Key West, and it's driving me crazy. So finally I said, I need to get in to see a chiropractor, right? So finally got in. She's like, well, is it that bad? You know, like what's affecting it? And I was like, no, it's not that bad. And I was face down on the table, and I was like, you know what? Actually, it is that bad. Like, I don't have time to be here. I wouldn't be here if it wasn't.
Right.
So I finally was like, I tell my patients not to do that. And here I am doing that. Right? Yeah. Because as women, we are everything to everyone all the time. And we prioritize everyone's health over ours. Even though we make the majority of the healthcare decisions for everyone else, we're terrible about doing that for ourselves. So what I will say is typically the women at that age, they're miserable. That's why they're coming to see me.
Yeah.
Yeah.
Yeah. So it's gotten that bad.
It's gotten that bad.
Right.
And I know it's that bad. Right. And I love it, especially when I have labs in front of me. I'm like, are you ready to feel better? That's exactly. I've never even met them before, but that's the first thing I say to them.
How often do people cry when you ask that? Because like that, I'm going to be honest, this is vulnerability. When you say that, I'm putting myself in their seat. That makes me emotional. And you're not even asking me, right? But just the idea that person has felt like crap and they've felt lost, and you ask them that question, I can just sense like the tissues are going to have to come out.
And it's interesting because maybe I haven't even met the patient. Maybe they got labs first, right? So they're walking down the hall. We're going back to my office. As you know, I'm the last office on the right there, currently in our current location. And I close the door. I'm like, you have to feel bad. I'm like, are you ready to feel better? And they kind of look at me like, yeah, like I am ready to feel better. I'm like, okay, let's do this. Because they've never had a provider talk to them in that way, right?
Yeah.
They've always probably had providers be reassuring. And I'm not saying that I'm not reassuring, but I know as a female, as a mother, as a working mother, I'm not prioritizing an appointment if I don't need it.
Yeah.
Truly.
Love it. Yeah. That's impactful. Yes. And that idea that, like you said, it's not even, it goes beyond reassurance. It's this, I got you.
Yeah.
You know, like I understand this. We understand you, what's going on for you. I heard you, importantly, which probably doesn't happen enough. And let's go to work.
Right.
Right.
And how much work do you want to do right now? Right. And that's okay, because I'll meet you where you're at. Yeah.
And that'll evolve as they feel better and you get that little bit of ground. Okay, now let's step it up. I want to ratchet as we get better and better.
More tools in the toolbox.
Awesome.
Yeah.
Oh, we could do this forever. So I think that's a good place today. This conversation is, like I said before, it's something I've been very excited about. It's this idea that you can approach medicine and these problems differently. And I think that precision matters. It changes how you approach a problem. It changes how you provide treatments to a patient and how you pay attention to how those treatments are influencing that clinical picture. And it's very different. I think that is a drastic change from what most patients experience out into the world. I know it's what I haven't experienced it ever when I go to the provider. It's funny because Jordan's not my provider, but we'll ask her, but she's still approaching me that same way. She does that to everybody. And I think we've attracted people who like that, right?
Right.
Both patients, but also the people who are at the office and they all feel it, right? And they want to employ that for the patient. So I hope this has been impactful for everybody else as it has been for me and thinking about this. And I think this is something that if you're thinking about doing it differently for your health, there are people out there. Maybe you're not even local to us, but your providers need to be able to communicate like this. They need to sound like this. And I think that's important because we get that question, how do I find somebody like you? Well, you might be in Minnesota. I mean, I don't know, but find somebody who communicates this way and speaks to you in that way and has that relationship and spends that time. And that part is important. So we're going to spend a whole lot more time deep diving, lots of science on this. Hopefully every episode you're going to notice that we continue to ratchet up to. And we will want to address topics that people want. So we want feedback. What do you want to hear about? I mean, I have all of these things and I'm a madman and I'm thinking about What do I want to talk about? What do I think is impactful? And we're going to get to everything. I want to talk about peptides and the nutrition and these other things that we're going to do. Our next guest is going to be a very interesting one to have on here. But I want to hear from the public and what do people need to hear to change their life. So with that, I'll transition out. And I want to say this, that until next time, Rihanna gave us very specific instructions to shine bright like a diamond. So we will see you back next time on Decoded. Thank you for being here.